We are live, right? It says we're live. This is Senate Finance, January 21st. And today we are going to take a second break from insurance. I really am waiting. We will have a caucus of the whole on Wednesday, I believe. Is it Wednesday or Thursday? We're doing a caucus of the whole. Here's the second page. Yeah, at 3:45, and I'm kind of waiting for the governor to reveal his plan, so we know where we need to start working. So we're going to look at health insurance. The cost of health insurance is there, right up there with property tax for affordability. So I've asked Robin Lunge to come talk to us. Robin, you were doing fiscal. Is that what you
Ledge Council?
Ledge Council.
Yeah.
Okay. But in the early days, when we were doing a lot of work on prescription drug pricing and then moving into single payer, Robin was our guru.
Thank you.
Or at least made sense out of everything we did. And she announced that she is leaving how many years the Green Mountain Care Board?
I am in my 8th year.
Okay. So I asked her to come and kind of share her retrospective on what Vermont's done, what it's doing, whatever she feels it would be good for us to know.
Great. So I also have Brendan Krause, the Director of Health Care Reform with AHS. Do you mind if we sit together?
Have we got a chair you can pull up?
We can grab one. I'll grab one from here, Brendan.
Somehow we have lost our witness chairs. We would actually have a decent witness chair.
If you recall, we changed the chairs to these so that they'd be more uncomfortable for our witnesses and that testimony would be much shorter.
Brilliant. And one of those Victorian straight back wooden seated chairs, but at one point we had an extra one of these help your back chairs that was down.
Well,
that was nice.
you may recall when I worked at Ledge Council, I had my own special chair because it used to be there was all the chairs around the side were worse than these, and I do have a low back, so I had an accommodation with my own chair that I would wheel between here and Senate Health and Welfare and Appropriations. And then I had one up in the house.
These chairs were not made for people under 6 feet tall. I'm watching my back.
Good. So why don't we start with introductions, and then we can jump in, and I'll tell you what I thought we would talk about today. As Anne said, I'm Robin Lunge. I'm currently a member of the Green Mountain Care Board. I am here today, however, in my individual capacity. I'm not representing the board. I did start my policy career at Legislative Council, where I worked for almost a decade on health and human services and the Medicaid budget, and then moved to work for former Governor Shumlin on healthcare reform, and from there to Green Mountain Care Board. So that's me in a nutshell.
And you did one little year stint in
DC. Yeah.
DC.
Yeah, that's true. I did not I'm not a city girl, so I didn't have to get into DC.
She came back.
I came back.
Thank you, Member Lunch, and thank you, Madam Chair and committee members. My name, for the record, is Brendan Krause, and I'm the Director of Healthcare Reform at the Agency of Human Services.
So what I thought we would do today is start high and way down. Whoops. And we okay.
Yeah.
Zoom.
I am not. No, I.
Brendan machine.
I'm sorry.
Somebody got a machine on. Okay.
Yeah.
I think,
Are we good now?
yes, as long as
Great.
no one's got their audio on, I think we're.
Got Okay. So I thought we'd start high and work our way down. So 2 years ago, Jessup Holmes, who's also a board member and an economics professor at Middlebury, and I did a round of talking about healthcare economics and how it kind of works in the US compared to other countries. So I'm going to do a little bit of that to start. Then I'm going to shift gears and do a whirlwind tour of Vermont healthcare reform history. And then I thought I'd turn it over to Brendan to talk about current state. So, great. So you can advance, and Brendan is saying other story to Brendan. This Brendan is helping me with my slide. Okay, so we're going to start again, as I said, at the highest level. So healthcare in the United States is considered a market, but it's different from other economic markets in this country, and its uniqueness it may justify, this is of course debatable, some of the government oversight through laws and regulation to try and correct some of the market failures that we see in this area. The bulleted points are really common economic principles, and I'm going to just spend a minute talking about how they play out in healthcare. So in most well-functioning economic markets, both buyers and sellers have complete information about the goods and services that they're exchanging. So an example that Jessica would use in her economics class would be if she goes down the street to the sporting goods store and she wants to buy a soccer ball, she knows what she's getting. They know what they're selling. There's a price there. She can shop around, see if somebody else is selling the soccer ball more cheaply. And it's a very even transaction. In healthcare, unlike that kind of goods transaction that we're used to, there's a lot of uncertainty and also information asymmetry. So when a patient goes to seek care, they don't necessarily know what they need. They're going to rely on the seller of the care, in that case, the doctor or the hospital, to tell them both what they need. And they are very unlikely to know how much that will cost when they're there in the office or at the hospital. And that's actually the case in this particular instance, often for the seller as well. So the doctor may not know how much the prescription they are writing will cost the patient, or how much the test that they're asking the patient to take will cost that patient. So unlike the kind of normal economic transactions in markets that we're used to, healthcare's a little bit more complicated because of this landscape of patients not knowing what they're buying, and physicians and hospitals really being relied on as experts and having more information to provide that patient. That's also true, of course, when you're buying insurance. So the patient or the person buying the insurance product, they will know their medical history. They will know how much risk they're bringing to that insurance company. The insurance company doesn't necessarily know that. And the insurance company, on the other hand, does have an incentive to want to have the healthiest population they can, because then they will be able to make more money on the premium. Of course, there's been a lot of corrections that we can talk about in that transaction, both in the Affordable Care Act and in Vermont, to even that out. It's also, as I think everyone knows, very difficult to know the price of a particular service. So even in states that have done a terrific job of price transparency tools, few people use them, and when they do, they're often difficult to use, because you need to understand exactly what you need in order to look up the price for that service. So in more recent years, the federal government has enacted requirements that both insurers and hospitals post prices to their websites to bring in more price transparency for patients. And that's really, the focus has really been on what are called shoppable services, meaning something that you can schedule, that you can perhaps look at more than one provider in order to actually shop around. However, because many patients are not paying the full cost and they're insulated from the full cost by insurance, those tools, even the really good ones, are not used all that often. So there was a theory, and many of those of you who've been around in healthcare for a while will remember the spread of high deductible plans with house savings accounts, with the theory being if you make the consumer more price sensitive, they'll have more incentive to shop. Then we ran into the problem that it's really difficult to shop for prices. So yeah.
On that point, is there any studies or reference points where the more we insulate them from the price, the more I'm generally asking this question, it's not leading, I don't know the answer. Does that translate to people consuming or requesting more health services? And that's also taxing the system more so than nations with other healthcare options? Are we overutilizing those that are covered?
Yeah, so I think there's some debate about what is like knowing when we're over or underutilizing can be very difficult to identify in healthcare. So there certainly is evidence and actuarial science is based on a premise that if the person is insulated from the full cost, they may use more. And if they, for example, there are some studies that show folks with high deductible health plans use less. However, there does not, because I think of this information asymmetry, people can't discern between whether they're using less of something they need or not. So with those high deductible health plans, you see people using less preventive care, as well as some of the types of services that you might want to discourage, like, going to the emergency room if it's not an emergency, for example. So you don't see really that the patients are able to really distinguish between, this is preventive, I really need to get this, so I'm willing to pay for it. It's more like sticker shock, I'm not going to get anything unless it's an emergency.
There are a few researchers right now that over the last sort of 5 to 10 years have been sort of calling into question some of the utilization and actually pointing out that it's the cost base in the United States that is really so different from other countries that we pay significantly more for pharmaceutical services than any other country.
Then crystallize that point. So what I think I just heard you say is that there's an argument that we're not using more health services, we're just paying a lot more for them in our healthcare system.
Yes.
In the US compared to other countries. Thank you.
I hate to ask the question, but why?
So in other countries, usually most other developed countries have government funded programs, and so they set prices. But I think it's more complicated than that because, of course, education is more fully funded in other countries. So a physician won't necessarily have the same debt load as in this country. So it's a little bit complicated, but that's generally why prices are less in other countries than here. I don't know if you
I agree with that. Yeah, I think partly it's sort of pervasive throughout our system. It starts in medical school. Medical schools are more expensive. Therefore, the salaries are more expensive. The cost of procedures are more expensive. Everything is it just sort of has a ripple effect.
And the tax structure is different in other countries.
Yes.
So if we provided free medical school to everyone, ultimately that would trickle down to lower healthcare prices. I mean, that's the argument I'm hearing.
I would argue that it's just pervasive throughout the whole system. But yeah, I mean, I think it starts there.
Start expensive, finish expensive.
I just want to add, it's not just medical debt going to medical school. I think that was just an example that Robin was using, but there are profit incentives throughout our entire medical system that lead to increased prices. That's just one.
I realize you're doing a presentation now. I don't want to interrupt it, but I mean, immediately from what I hear is then the question is, well, what are we going to do about it?
Well,
And
that's
who's
what we're
doing
gonna,
whatever it is?
We will get there.
Okay. Good.
Yeah.
Good.
we will be doing a lot of that for the rest of this session, I think.
Yes. And I do think, just on that note, what I would say is, I think the important point about Brendan's point is in healthcare, there are a number of problems and challenges, and one of the things I think that we've not done as well as we could have in Vermont is really focusing on what is the problem we're trying to solve, because we tend to think, okay, we're going to do this reform and it's going to solve all the problems and everything's going to be great. And we put too much pressure on a single initiative to solve everything, which is not, and I think that's partially why we're still doing this healthcare reform journey that we have been doing for a long time in Vermont. So
We always ask, when is it going to be finished?
yes. Well, I've been doing it for 20 years. So all right. So the next few slides are really just going to give you a sense of where we are in comparison to other countries. So the Commonwealth Fund does a study of 10 high-income countries, and they look at access to care, equity, health outcomes, administrative efficiency, and the care process. So prevention, safety, patient preference to get, and they wrap this into an overall assessment, and then they graph it. So as you can see that we tend to not do as well compared to other countries on these metrics that Commonwealth Fund has used. We can go to the next slide. And so as a result of that kind of comparisons, the US has really tried to focus in on the triple aims. So quality, cost, and access. This is now often the quintuple aim because we've included sort of the well-being of clinicians as well, for example. But these are sort of the three axes that in healthcare reform we tend to look at. You can go to the next slide. And I'm just going to whiz us through a little pulse of where we are on each of these. And there are other metrics that could be used. I just picked a couple to give you a sampling.
Just curious on that slide that had the US
Oh, yeah.
ranks last,
Yes.
and you mentioned, I don't know, 5, 6, 7 different categories. What draws down the US?
Well, I think it's a combination of all of the factors. What we can do is certainly, I can give you the study if you'd like, and that will really give you the depth on it. But certainly, we'll go through some slides that show on health outcomes. We tend to not do as well as other countries. And
What about,
Access.
what about administrative costs?
administrative costs, compared to, it depends on the system. So if you look at a system where it's 100% government run, then our administrative costs will be higher because we have multiple people doing the same types of things. So we have multiple insurance companies with multiple insurance computer systems, for example. And that tends to be more costly than if you have one entity using one system. So we have some redundancies in our system because of the market-based approach that we have.
There are some studies that put it at 30%. That actually 30% of our system is wasted on administration, but to Robin's point, it depends
The
on
entire system.
it depends on what you count.
Yeah. Yeah, and it's we did a deep dive on that in Vermont when I was working for former Governor Sutherland. And where it gets tricky when you're trying to apply it to a state is if you're a doctor's office and you have two people who man the front desk and they do the appointments and they do the paperwork and they do all the billing, if you no longer have to bill, are you going to really fire one of your two people, or are you going to find something else for them to do in the practice? Like in healthcare, the administrative cost is of course technology, but also is people processing things. So I think that's where it gets administrative cost comparisons get a little tricky, and especially in terms of simplification and how do you make those more efficient, because there are people and jobs involved in there too. All right, so just a couple different measures of access. This particular slide shows the uninsured rates between 0 and 64. You'll notice often when we look at access, insurance tends to cut off at 64 because folks are eligible for Medicare when they hit 65. So this is the commercial, really showing the impact of Medicaid in the commercial market on the state's uninsured rate. The overall in 2023, which was the most recent data we could find, uninsured rate in the United States is just under 10%. When I started doing healthcare in Vermont was about 10% actually. And now we're down to 3%. So Vermont and Massachusetts are the two states that have, and Hawaii is usually up there, 3 states that have the lowest uninsured rate. And that really shows, when we go through the history, it really shows our focus on ensuring that people have access to insurance. Now, this doesn't tell the whole story because, of course, what kind of cost sharing or what people pay when they go seek services also it can be an access issue. So if we look at the next slide, this gives you a little bit of information about how people report their use of healthcare based on insurance status. So really the takeaway here from the uninsured column is that people who are uninsured don't tend to see the doctor or healthcare professional unless it truly is an emergency and are going to the emergency room. And certainly you can see that that's not non-existent in our other coverage areas. So some folks on Medicaid also don't seek care, and some people with private insurance don't seek care. But in general, whether you have insurance or not does dictate your willingness and ability to go to seek care outside of the emergency sector. So we're going to shift now to cost. So what this chart is showing you is the United States, which is the top red line, historically, the healthcare spending as a percentage of gross domestic product compared to other higher income, mostly European countries, although Australia and New Zealand are in there. And you can see that in 1980, we were at the top of the pack, but we were not an outlier. We were, still within the grouping of all these states. But then since then, and the most recent data here is 2023, we in general have outpaced other countries in terms of our healthcare spending. The little sharp up, it's kind of the flat and the up is COVID related. Yeah, that's 2020 to 2021. And then if you compare us on a different metric of cost, which is per capita, United States per capita spending, the lower line, the blue line, bluish green line is adjusted. What this basically shows you that in 1970, we started at a little over 2,000 per capita dollars per year, and that now we're closer to 14,000. So this just shows you for just the US how that spending has tracked. So that raises the question of why. Why are we an outlier there? And there's several theories. I don't think there is a definitive answer, but here are some of the theories. Economists would certainly argue that having good insurance coverage creates utilization pressures, as we already talked about. And there's certainly arguments about the fee-for-service reimbursement system driving care. So fee-for-service is the payment method that is most widespread in this country, where every time you use a service, you're billed for a particular service or good. So it's really, the more the doctor does, the more income comes in the door. So that's been an argument around for quite a long time, that because of that, it really pushes volume over trying to understand, promoting the highest value care. So preventive care, for example, would be an example of high value care, because you're preventing future illness and future spending, as well as, of course, from a human perspective, future illness. Technological growth is also one area of healthcare that tends to drive spending. Unlike other sectors, technology in healthcare tends to drive up cost, not down cost. I'm not an expert in technology, so I really don't know why that should be the case, but that's what's been observed. Other countries may not see that quite as much as we do, because since they have systems where there is a government entity paying for coverage, they tend to control the types of technology and when it comes into play. So you probably have a better example, Brendan, than I do, given your international experience. But certainly, if there's something that may be really useful for one population, but only marginally useful for another, here in the United States, we don't say, no, you can't have that because, it hasn't been proven to work for you. We just make it available. In other countries, they have more limitations on what you can get when, based on study. And that's certainly the case with prescription drugs, but I think with technology as well. Another theory is that in the United States, we rely very heavily on specialization. So here it's about 30% primary care to 70% specialty care in the United States. In other countries, those numbers are flipped. So they really have a focus on primary care, and they produce more primary care doctors and less specialty care doctors. Now, there are obviously pros and cons to that, but overall, if you're relying mostly on primary care, it tends to be cheaper. Yeah.
So I don't know a lot about universal healthcare, but it would seem to me like these last 5 items would be true of a universal healthcare system or a system like we have. Everybody in a universal healthcare system is effectively a third-party payer, right? They're shielded from the true cost of the.
True.
So why do they have less than we do?
Yeah, so that's why I said this is an economic theory, right? Because if you just look at that, you would actually argue that universal healthcare systems should be more expensive, because they tend to have lower cost sharing. So I think that is a theory that has been promoted in the United States. I don't know that it necessarily tells the whole story. Technology, I think it's because there is more constraint on use of technology in other countries. Specialization, they're not as
They're not
specialized.
specialized.
Yeah. Aging in the population also comes up, but again, to your point, that doesn't necessarily explain us versus other countries. It just may explain some states versus other states. Vermont, for example, is an older state, and so older folks tend to need more care, and that will drive up your per capita spending. And then I'm going to skip over income growth just in the interest of time, but
I would
price is also, I think, an issue. But go
I would
ahead.
just jump in. I worked with and received my care from the National Health Service in the UK for 12 years. They have a very strong gatekeeper. So in addition to the sort of the pervasive costs that Senator Curry mentioned, is also the fact that you don't go to a specialist until you've seen your primary care doctor.
And I think,
And they decide what specialist you will see.
Okay.
and I think the other piece that you had mentioned or we talked about earlier was, in general, physicians don't get paid as much in other countries as they do here. So that will also impact on.
I know it's super complex. At the same time, the fact that we are dealing with theories and not actually able to quantify this, I find super frustrating. It just seems like
Yeah.
we should be able to run the numbers. People are people, humans are humans. So, that's one thing I wanted to say. The other thing is it'd be interesting to look at things like is corn subsidized in
Mhm.
Europe? And
Yeah.
why are they not allowed to put PFAS in their reindeer and we do? And the contaminants in the environment and so
Yeah.
on. Those would be probably harder to quantify, but
Yeah.
I don't know. It just, I get frustrated that we can't
Yeah. I think
sort this out.
it's difficult, particularly when we're trying to compare ourselves to other countries for exactly some of the reasons that you raised. Like, it's not just the medical care system that impacts on the cost of healthcare and the type of healthcare that people use. So it is complex, and I think people have tried to figure it out, but I think the complexity masks and makes it hard to really pinpoint.
Yeah, and I shared in Health and Welfare today that, the efficiency in the system, I've lived in many different countries,
Oh,
the
great.
efficiencies of their system where money's taken out of your paycheck each week or every couple weeks, regardless of your health or lack thereof. It's the ultimate risk pool. Everyone's paying in.
Yeah.
And it's just so much simpler as someone who was on the receiving end of care.
Yeah.
Anyway, thank you.
Yeah, no problem.
Can you go back to slide 6? The health insurance access varies by state. I didn't peek ahead to your other slide, so I don't think you're going to speak to my question.
Yeah.
So on that slide showing the US and
Yeah.
the access varies by state.
Yes.
This is a genuine question. I don't know the answer to it. Is there a correlation between healthcare affordability and how much we have health insurance access? So are the states that are lighter purple, are they struggling with more expensive healthcare like we have here in Vermont than Texas or Florida?
That's a great question. So I think, let me break down affordability, right? So when I think about affordability, I think about affordability in terms of premium prices and also affordability in terms of how much the patient pays when they go. There are other metrics of affordability. You could look at it as a percentage of the state budget as one measure for the taxpayers. So it would depend on which metric you picked. And I don't think it would correlate exactly. So I think what's really driving the uninsured rates here is the extent to which the state had decided to expand when the Affordable Care Act came in. And so, so states who did not expand Medicaid tend to have higher uninsured rates because, of course, then you have people at the lower income levels unable to purchase private insurance. So I think that's really what's driving some of this disparity. Now, whether or not, again, like if you have more uninsured, it will be really unaffordable for those insured people. Whether that means that it is unaffordable for people paying a premium, I don't think necessarily is always true. So for example, I think if you looked at the private insurance market in Texas, my guess is that it's not necessarily that expensive, but they also probably have not required insurance to cover the same level. So one of our issues in Vermont is we have and I'm not saying issue in a bad or a good way, just one of the factors, I guess, is that our insurance products are rich. They were rich prior to the Affordable Care Act, meaning they cover a lot of stuff. You don't find many states where, for example, you have chiropractic coverage, not to pick on the chiropractors, or naturopathic coverage. Those are common here. That's my guess is you would not find that in Texas.
You're just circling the point that I'm trying to confirm.
Yeah.
My understanding is I wanted to be able to say that Vermont has more expensive healthcare because we cover a lot more people and a lot more services. As opposed to other states that don't cover as many people, haven't extended Medicare. They have lower private healthcare insurance, but they're not providing nearly as much access.
I think that's true if you look at total spending. If you're looking at the cost of the premium, the other key piece there is price, right? So it's what you cover, how healthy your population is, how much what your medical culture is in terms of utilization, and then price.
And Texas, most of these other states don't have community rating. So if you're 25 in Texas, you're gonna get really cheap insurance. You turn 50 and you're gonna pay basically the cost of your group. So when you need it most, it's going to cost you the most.
Yeah, that's very true. And in fact, when you use some of the comparison tools, that's not really taken into consideration because they have to pick an age for every other state that doesn't have community rating. And so if you pick 20, we're going to look terrible. If you pick 55 or 60, we're going to look great. So that does kind of confound the comparison a little bit. So, if you pick somebody in the 40s, I think we tend to look high. All right, shall we move to quality, which I think is slide 10. All right, so 2 quick looks at quality. There are obviously many other components to look at quality. The first is a blunt instrument, which is life expectancy, but that's something that's measured across the world. So you would think, and I think most people would assume, if you're spending more money on healthcare, your quality should be better, but that does not necessarily bear out. And if we go to the next slide, you can see that life expectancy in the US also really varies based on where you live. And the graph here shows the red is an average age of 60, almost 67. And at the higher end, an average age of death at 87. So one of the challenges, I think, in the United States is that socioeconomic factors really play into these kinds of quality metrics as well, which I think then, actually, let's skip ahead to slide 13. Yes.
Well, actually, can you go back to that slide?
Yeah.
That's an amazing graph.
I just, if you overlay this graph, Senator Chipman, with the other graph about where the insurance rate, there's definitely a correlation. If you see the red down there, that's the states that have the lower percentage of insurance coverage. So fewer people have access to healthcare down there. Fewer people are covered by Medicaid. They die younger. So health outcomes and health metrics in terms of how healthy is the population, how many people smoke, how many people, get access to prenatal care, et cetera, et cetera.
I'm wondering if the dark red might qualify in any way with reservations, because natives with reservations are known for having very poor healthcare outcomes.
Yep, you can certainly.
Just where they're located.
Yeah.
And a lot of
I
people.
wonder.
Yes, yep. Yeah, and other policies, like what kind of public health system you have for alcohol and drug misuse disorder treatment can also impact things like this. So certainly we know overdoses kill more than 100,000 people each year. That will have a big factor. So the public health system in your state can also have a big impact.
Social
Right,
safety.
like this, and the social safety net, yeah. So when you look at us for how much we spend compared to how we do, again, we're not where we want to be. We want to be up and to the left. We want to be lower cost and higher quality. So I'm going to change gears in a minute to healthcare reform history, but just to sum up, if we can go to the next slide. Many of you who've been around the block in healthcare will recognize this slide. So it's not just your health system, your health care system that's going to determine how healthy your population is. And certainly because that only accounts for about 10% of predicted value to the outcomes. Lifestyle choices, socioeconomics, genetics, these all matter a lot and much more than your actual health system in terms of health outcomes. So it's just good to keep that in mind when you're thinking about, like, if you're focusing on cost, what are some of these other factors which you might be able to invest in to result in higher outcomes?
So now it's kind of like making the exact same argument that was just made about overlaying those two graphs where you have access to healthcare and the cost and how many people are insured. And now it's saying, well, only 10% of that really goes into.
Yeah, so the way I would say it is if you don't have access to healthcare, you're going to have bad outcomes. We know that those are correlated. But if you have good access to healthcare, that's not the only thing that's going to make you healthy. In fact, some of these other factors are going to be more important.
Well, it looks like 70% of your outcome is going to be based on just you being born and what you do throughout life.
Yeah. Yeah, and your built environment. So do you live in a place where you can get outside and walk and
Right.
exercise? Is that easy for you to do?
Right.
Do you live in a place where smoking is hard? Like if you are a smoker, it's actually harder to be a smoker than not be a smoker because of the policies the state has done. So that's where the public health system really comes into play in terms of impacting on the overall health of the population. So there's a lot of different factors that play into it. Yeah. Okay, next slide. So back to where we started. When markets aren't functioning, what happens typically is somebody steps in to try and fix the problems. And so these are just a few examples of ways that government policy and regulation and healthcare have come into play to fix some of the things that we've talked about. So for access, public coverage program for poor elderly and children. So the Medicaid expansion that was included in the Affordable Care Act, and that quite frankly, Vermont had done prior to that through Medicaid waivers. Like Vermont used Medicaid waivers very effectively to provide coverage for our lowest income and seniors and kids. So we have near universal coverage for kids now. We only have about a 1% uninsured rate for kids, maybe even less at this point. An example of cost containment is at the federal level, antitrust laws. So typically, if there isn't competition in healthcare, which often in many states there aren't. For example, if you look at Vermont, we have 14 hospitals that each have their little geographic catchment area. There's very little competition in between those hospitals. There's some. People, particularly in central Vermont, where here we could go to up to Berlin, we could go up to Copley, we can go down, towards Dartmouth, we can go up towards Burlington. So we're very centrally located and have actually quite a bit of choice. But if you're in Bennington County, you're going to Bennington, right? If you're in the Northeast Kingdom, you're going to your hospital that's local. So antitrust at the federal level is trying to infuse more competition, particularly among big pharmacy benefit managers or big insurance companies. In terms of consumer experience and quality, we look at licensing as a way to improve quality at the very most basic level. And then FDA approval of drugs, for example, is another quality. And then I think we have some experience of quality improvement in Vermont through the Blueprint for Health, which we'll talk about in a little bit as well. So shifting to what Vermont has done, Here is recent history of Vermont healthcare reform on one slide. But we'll take our time. In 2005, there was certainly some healthcare reform that happened before 2005. There was at least one run at creating a single payer system in the 90s. Vermont's had hospital regulation on the books since the 70s. Dr. Dinosaur and other coverage programs happened before 2005. Before 2005, there was a huge emphasis on increasing access to insurance coverage. But 2005 was when Vermont's Global Commitment for Health Medicaid waiver came into being, and that waiver allowed more flexibility in how the state could spend Medicaid dollars, and allowed the state, and has continued to allow the state, to really focus on providing some of those dollars for prevention and other sorts of health coverage that isn't typically covered by Medicaid. Yeah.
Nolan was in the other day and talked about
Great.
the waiver too.
Okay.
But my memory was we got a waiver, there was a cap, and we got flexibility within that cap to do things that would provide better health outcomes for the same amount of money we had been spending.
Yes.
That's what the waiver was about, not
Yeah.
just that we could do more things
Sure.
and spend more money.
Yeah.
We could be more creative. So we worked on a lot of prevention programs.
Yes, exactly. All Medicaid waivers will only be approved by the federal government if they are budget neutral to the Medicaid program at the federal level. And of course, whatever flexibility you get in a Medicaid program is still subject to the appropriation process at the state level. The state has a match it has to contribute. So that, often dictates how much that Medicaid waiver is actually used based on what state funds are available. And you should jump in whenever you want, Brendan. 2000.
A lot.
Okay, 2007, Vermont expanded insurance coverage through Catamount Health, which was an insurance product that was designed actually in the legislature and had set statutory cost sharing, which when that had to be changed was quite a process. That provided, it was a slow ramp up. It took a few years, but I think eventually it had about 10,000 covered lives. But then when the Affordable Care Act came around, it really didn't fit with the Affordable Care Act's design of insurance markets, which was a real change. And so that program was sunset when the health insurance exchanges came into being. In 2008, the Blueprint for Health was started, and the Blueprint for Health. Do you want to talk about the blueprint? Or do you want me to keep going?
You could,
Okay.
happy to jump in.
All right.
You're on a roll.
Yes, I am on a roll, I guess. So the Blueprint for Health is the state's primary care medical home program. And what makes it unique as a medical home program is that in addition to payments, per person payments that go to the physician's office to support them to do things like care coordination for their patients or wraparound services for their patients. Vermont also funded something called the community health teams, which are teams. There's one in each region. Now, sometimes you'll hear them called accountable communities for health. They're basically a coalition of all the different provider types and other folks in that community to work on how to provide wraparound services for the patient. And that ended up being Vermont's secret sauce. So the Blueprint was evaluated with a number of other medical home programs across the country. And the federal evaluation showed that it saved more dollars compared to these other medical home programs. And really what was distinct about it was the community health team structure.
And I think it creates a tangible infrastructure upon which further reform can be rolled out and scaled. Unlike other states, I think it's a very unique model that could be used to drive significant transformation going forward.
Yeah, and one example of that is the Hub and Spoke program, which is for substance use disorder, misuse disorder treatment. And that was rolled out as on the Blueprint infrastructure so that there was really a way for providers to easily plug in and have their patients plug into these new services. In 2011, the Green Mountain Care Board was created, and the Green Mountain Care Board is a 5-member independent board that regulates the private part of our healthcare system. So we do health insurance premium review. We look at certificates of need, which are really almost like permissions to build new infrastructure or buy expensive equipment. It's meant to kind of provide a check on the expansion of healthcare services and infrastructure. And we also do our other huge responsibility is hospital budget, reviewing hospital budgets. We have hospital revenue growth every year as well as commercial price growth as a way to reduce spending on healthcare, on hospital services. So the board actually, when it was established, many of its duties were being performed at an agency called VISHCA, Banking, Insurance, Securities, and Healthcare Administration, now called Department of Financial Regulation, or DFR. I lost the acronym. I wanted to call them FinReg at the time, but now I lost the acronym battle on that one. So DFR now focuses on the insurance part for all types of insurance, and then the duties that were healthcare specific get rolled up to the Green Mountain Care Board, with the idea being that a public body that is subject to open meeting law provides much more transparency into the process. Whereas before, even though there were occasional public hearings, it was not nearly as transparent and open a process, for better or worse. 2013, Vermont Health Connect was launched, and boy, was that rocky. I lived that one. I still have PTSD from that. So Vermont decided when the Affordable Care Act was established to do its own state-based insurance exchange instead of relying on the federal government, which could have provided one. And basically, that Vermont Health Connect provides a technological infrastructure for people to shop for insurance and also to sign up for federal and state subsidies to help pay for that insurance. I think a lot of the kinks have been worked out since 2013, thankfully. But that is now one way that individuals shop for insurance and purchase insurance. In 2016, Vermont signed the All-Payer Accountable Care Organization model. The goal of that model was to bring Medicare into the state's healthcare reform initiative. So typically prior to this time, what would happen is Medicare was doing its own thing. They're a federal program. States don't really get any say in the federal program. And they kind of run their own system of coverage for seniors and individuals with disabilities. The All-Payer Model Agreement gave the opportunity to bring the Medicare ACO program into better alignment with the Medicaid ACO program and allow the states some say into how that program was run. The All-Payer model actually sunsets at the end of 2025. And I think most people agree that it certainly didn't live up to its promise that people expected in 2016. It has provided.
Would you characterize why?
Yeah, that is a good question. So the way our ACO program was structured is really different than the way most ACOs operate. Most ACOs operate on kind of a top-down structure. So they have data, they push data out to providers, and they say, you should be doing more of this and less of that. It's top-down. That was not perceived as really being palatable in Vermont, given our medical culture, that having something so top-down would not be received well. And providers wouldn't want to do it. And the Blueprint actually is an example of this. The Blueprint was really more of a bottom-up program where each community, at its beginning, each community designed their own community health team. They designed their own priorities. It was very grassroots in the sense that each region was figuring out what they thought their region needed. And so I think the large accountable care organization, OneCare Vermont, really tried to then layer on top of that. And this is my personal opinion. I think that created some challenges because it requires a lot of knowledge and ownership at the local level. Comprehensive payment reform, which is capitated payment, so a monthly amount given to primary care, independent primary care to pay for the care of their patients. And that resulted in more resources for those providers, and those providers love it. So there are definitely some successes in the program and the model. But I think overall, we didn't see that the other problem was we did have a pandemic in the middle. So 2020 and 2021 were kind of lost years, and even parts of 2022 where providers, were not really focused on that activity. They were focused on COVID and the pandemic.
I remember hearing though that getting those payments kept some of them afloat
Yes,
during that time.
Very much
because
so.
people weren't coming in with the volume that
yes,
they had been.
yes.
Follow up to the answer, do you see in other states that have tried this that actually achieved success where they had more top-down control and consistency through less honored local control and instead more of the management you just described?
Yeah, it varies by ACO. So in other states haven't really tried to do it on a statewide basis. So that was the other thing that was unique about our model is we're trying to do it on a statewide basis. In other states, you have an accountable care organization. It's a private organization. Providers choose to join, and they may be in a region or they may be just with one provider. So we have 3 Medicare ACOs in Vermont today. They each have one practice that have joined them. We haven't really seen the results of those yet to see whether that's creating improvement in that one small thing. But for the most part, they're smaller and more targeted. So I think you see some success in some places and less success in other places. So it hasn't been a model that has been clearly 100% successful. It's very mixed in terms of the results.
Yeah, I would say, just speaking from an outside perspective, if you look at states where it has actually worked, like particularly in the Northwest or California or Massachusetts even, they tend to be organizations that are composed of multi-specialty group practices. So they have the ability to provide a lot of what we in Vermont would go to a hospital for outside of a hospital. And so they have a very strong incentive to continue to serve those patients outside of the hospital walls, which saves money. And so if you look across the country, the successful ACOs tend to be those that view the hospital as a cost center rather than having the ACO under the tent. But we don't have multi-specialty group practice in Vermont, so we have to think more creatively.
More follow up. To those examples, Massachusetts, California, and so on, have they lowered or raised the threshold to trigger the certificate of need so it's easier for people to provide health services so as to provide them at a lower cost than what hospitals are providing?
Yeah, I do not have that data in my head, but I do have a map of certificate of need laws and where they are. If you've seen one CON law, you've seen one CON law. So you really have to look at, usually there's a different threshold for different things. So I think it's fair to say that most states do have higher thresholds than Vermont. What I would probably do is look to other New England states, just because it's a little more similar in terms of the healthcare delivery. But certainly I think that data is out there in terms of comparing the jurisdiction.
And a lot of what those ACOs would do would be literally just specialist care. So, I, for example, go to the dermatologist at a hospital, like that wouldn't happen normally in a typical ACO, you go to the ACO.
Yeah.
So, and they also, because they know so much about their population, and these also tend to be Medicare shared savings programs. They're able to take risks, so they can take both upside and downside risk, and so they have more flexibility in what they choose to pay for and how they choose to pay for it. So they can do more investment in team-based primary care and those sorts of things.
Maybe not super well. Oh, sorry, Scott.
Robin, let's go back to 2013, sorry.
Sure. Yeah, let's do it.
I see a lot of ads today for healthcare.gov. Would a Vermonter use healthcare.gov, or do they have to go through Vermont Health Connect?
Yeah, they have to go through Vermont Health Connect. Healthcare.gov won't have Vermont plans
Okay,
on there. At least I'm a little out of date on the exchange, but I think that's right.
okay, thank you.
Sarah's saying yes, and she did.
Okay. All right.
Yeah.
Thank you. Is it true that not all countries have certificates of need? I believe, for example, France doesn't do CONs. They do have periodic evaluations by the government, but they don't necessarily have CONs. Do you know if that's true?
I don't know other countries. I've only looked at other states, and there certainly are some other states that don't have CON either. There's a lot of I think there are 35 states that have CON laws, and there's a lot of variation there in terms of what triggers it and how much triggers it. Yeah.
And then, One Care Vermont's going away. Is it this year?
They had said that they're going to close up at the end of this year, yes.
Okay.
I
'Cause it
can't
always-
remember if it was 2025.
Yeah, I thought,
They continue they have some obligations in 2027 that they'll honor in terms of reporting.
oh, okay. Cause it always, like, the framework of One Care was to have this organization that sends out population-based payments, and they were looking at the amount of money that they were spending on fee-for-service care. So they're switching that to a population-based payment, and that's the payment that they send out to all these providers. And I never understood why you would take that same amount of money, take an administrative fee off the top, and then divvy out, say, 85% of that money that you spent already, and it got sent out to different areas. How, like, fundamentally, how did we think that would save money when you're taking an administrative fee off the top of it?
Yeah, so I think the theory was that if you're redirecting it to primary care and prevention, that you will save money in the long run because of the care that people are using. But yes, to your point, there is an administrative fee there. But that it was coming largely from hospital dues. So it was money that was in the system previously as well. It just, the money got shifted around.
Did we have positive outcomes? I mean, I'd imagine no.
It's been mixed. So we, as a state, we have, so if you look at, so the other piece of the all-payer model that I didn't touch on is it also had an all-payer total cost of care measurement system. And a Medicare measurement system. So if you look in terms of the overall spending, it actually, the model as a whole was successful. So Medicare until really recently, and we don't have the data yet for 24, but 24 is looking like we're going to be growing faster than we had agreed to, which was 3.5 to 4.3%. That percentage was based on historical economic growth prior to the signing of the agreement in 2016. Overall, we've stayed within that growth target until maybe 2024. I don't have the data, I haven't seen the data yet, so I'm caveating that because I don't know for sure which way it could go. But the federal evaluation of Medicare spending does show that Vermont saved Medicare money.
But private, not so much.
Well, the federal evaluation is Medicare's evaluation,
Just
so
Medicare,
they're
okay.
not looking at private.
Okay.
Yeah, and there wasn't really large adoption of ACO programs in the private sector.
So
So there was some at one point and through the exchange population, but I wouldn't say it really hit on the total. If you look at our private commercial insurance sector, a large component of it is self-insurance.
I hesitant to get into this. Well, I mean, one of the problems with the ACO is we just never had enough lives in the ACO to make it a full sort of statewide program. There were what was the percentage of covered
I
lives?
don't have it in my head anymore, I'm afraid, but yeah, we had expected to get more take up in Medicare from smaller hospitals than we actually did. And so that limited that, and the primary care participation limits the number of people who are actively in the ACO.
And then the ACO was never able to provide the kinds of services that were necessary to provide to be successful. And they ended up it was another sort of profit incentive in our healthcare system that they used a lot of the funding for administrative and salaries, not actually improving the healthcare. So overall, it was
Data was a big challenge.
yeah, they didn't ever provide the kind of data that was helpful to healthcare providers and to do their work.
We did.
You don't know what
I don't know, well, Robin, you would know better than me about the PCO.
Around 15. Yeah.
15.
It did vary over time, but that's my recent recollection. Yeah. With the data, I think it was interesting because we did get different stories from different providers. Some providers really loved the data and some providers said this data, I just don't know how to use it. And so you did see a lot of variation in the community based, I think, on the sophistication of individual people at individual provider organizations. So,
But that was one of the selling points was that
Yeah.
they have like
Yeah.
really great
Yeah.
data analysis and you're gonna be able to tell how to, what services to provide and how to make your population better and everything. And I was at some of those early meetings where
Yeah.
people were super optimistic
Yeah.
how to
Yeah.
like data informed healthcare and it really just
didn't come to
never
pass. Yeah.
came to pass.
That's fair. All right, I want to be mindful of time.
You've got 15 whole minutes.
Okay, so I think we should skip the rest of the history because it's all fairly recent, and so you'll get caught up on it.
Actually, I found it helpful.
Oh, good.
If you're in health and welfare, these terms get thrown around
Yeah.
and they get conflated and confusing. And so this is helpful.
Good. So I'm going to turn it to Brendan.
Okay, and please jump in because a lot of this is your data. So fast forwarding or transitioning to the vision for healthcare reform. So the vision for the state is, or our shared vision at least is that the care that Vermonters will have the care they need when they need it, where they need it, and at a price they can afford, which is the challenge we're facing right now. So the context for where we are today at the state, as many of you will know from your own perspectives in the state, the system currently is facing significant challenges in affordability, sustainability, access, and equity. Health insurance premiums and out-of-pocket maximums have risen dramatically over the last 5 to 10 years, particularly in the state-regulated market. More than half of the state's hospitals are operating at a loss. Vermont health insurers are facing financial sustainability issues as well at the same time as the hospitals are. Vermonters are experiencing increased wait times. We'll show you some data about that for primary and specialty care. Gaps in community-based care are resulting in increased uses of hospitals. So it's one of the things that we were talking about before. And then low-income populations, and particularly in rural areas, are facing significant health-related social needs, and we have some data to support that and show you that as well. Please.
Memory check for me. When we started, if I remember, Vermont had some of the lowest hospital costs in the country. And we now have some of the highest.
That is a good question. I would need to go back and look because I don't recall that data around that.
That's
20 years ago.
And it may be totally incorrect, but I did a lot of NCOIL.
Yeah.
Since you do insurance in this committee, that is the National Conference of Insurance Legislators. And you're all welcome to be members and go to their meetings. They would love to have you. But you do learn a lot. I can't say they're the most scintillating conversations I've ever sat through. But I have a certificate somewhere that says I'm a certified legislator. Because I went to classes during lunch. But you do learn a lot. And that just stuck in my mind. So if it's.
I'll see if I can dig that. I'll see if I can dig that out.
I think when we were doing community rating, that may have come up, that.
Community rating was actually before my time, Anne. I'm
Yeah.
sorry to break it to you.
Well, I think it was before mine. I didn't do it. But I do remember some of the
Yeah.
discussions.
Well, that's true. Let's do it back to the future exercise and.
Sure. I need more.
We certainly have as a state, at one point, we were one of the lower cost states because we tend to be very up in the health, some of the healthiest states.
So next slide, here are some examples of premiums and wait times. So we're seeing this increased in Vermont approved TFCD approved health insurance premium changes. But at the same time, we're also seeing pretty stubborn delays in wait times. So the percentages of new patients, both for 14 days and 31 to 90 days, being seen, or rather being seen between 31 and 90 days is stubbornly high for particularly considering how much we're spending. And then on the next slide, you'll see that, more than half of the hospitals are operating in negative margins. And so there's obviously been a lot of analysis done, particularly by the board over the last 6 months, that is unteaching some of this and unpacking some of those gaps and some of those shortfalls that need to be addressed. And this is just the next is an example of the claim surge that particularly private insurers have seen over the last few years. And in this scenario, we're seeing now basically over the last 4 to 5 years an increase of almost double the cost, the medical and pharmacy costs compared to 2020, excluding Medicare. And so what we're seeing is a lot more cost and a lot more claims intensity. And the hospital income sustainability. And then this is all happening against a demographic shift that is not going in the state's favor. So our population is aging. We're one of the older states in the country, and parts of the state are actually the oldest regions in the country, particularly in the Northeast Kingdom. And a lot of those communities also suffer from significant or face significant health-related social needs, meaning that these are not necessarily healthcare costs, but they have direct impacts on people's health. So 14% of Vermonters spend half or more of their income on housing, and 14% of Vermonters lack access to broadband, which is, among other things, an inhibitor of economic development. And then 9% of Vermonters are food insecure. And you've just talked quite a lot about the current all-payer model, so I don't know if there's anything else on the slide that you want to address.
I think we can keep moving.
Okay. And just sort of to revisit where we are now, this particularly focuses on the payment models, because that's what we've been talking about today. But Act 167, which was passed last year, many of you obviously either were directly involved or voted for it, directed the agency and the Green Mountain Care Board to perform a number of tasks. One was to consider a different federal model for multi-payment of healthcare. So as this all-payer model is going away, to look at other options, to design a potential hospital global budget, to proceed with a robust stakeholder engagement, exercise and analysis of hospital transformation, and that's the good work that the Green Mountain Care Board did over the last year, and then to translate that analysis into on-the-ground technical assistance to support hospital transformation, which is where we are now.
Okay, so in health and welfare, hospital transformation gets, what I'm not clear is, what are you transforming them to?
Yeah, I think
I wasn't there for once.
Yeah. I think it's a great question. So the purpose, the Act 167 provided funding to hire a contractor who spent, was it really just last summer? I think it was.
And
fall, going around the state, talking to a lot of people. There were tons of community meetings. And the purpose of that study was to come forth with some proposed ideas for how each individual hospital could become more sustainable. So addressing the slide earlier that showed the hospitals in the red with negative margins, and also allow for this shift to ensure that for a statewide affordability purpose that we can pay for the infrastructure that we have in a way that promotes essential services in every community. So the sort of the theory of Act 167 when it was going through the legislative process was, we know we need essential services in every community. We also know that our insurance premiums are increasingly unaffordable. So we're in this situation where we don't know what to do. We need to figure out how to ensure that people can get the most basic essential things in the communities. And so the idea was to take a look and see what experts might say were some possibilities. And so that report came in over the summer. And then I think people are taking a step back and looking at the recommendations and kicking the tires on it. So it's, one consultant's report, some of the ideas I think people like, some of the ideas people don't like. And so it requires, continued discussion. But there's not going to be a one size fits all, I don't think. I think what's going to work for one region may not work the same for the other region, because each hospital has unique challenges, and some of them are profitable and some of them are more efficient, and vice versa. So it's going to have to be looked at on a hospital by hospital basis, because they're not all the same. I'm not
No, that's
involved
right.
in that work.
I would
but
taking
that's my
I'm taking a step back, we're taking a step forward.
Okay,
But,
sorry.
then that's happening now. So, for example, we will be going up to the Northeast Kingdom this Friday, and we've engaged the technical assistance provider with experience in rural health system turnaround. So, that process is underway. So we'll be on the road a lot, working with hospitals.
Yeah, and AHS is the lead on the transformation.
Well, we're partnering with the board.
Yeah.
So they're
I personally am not involved.
a couple of years out.
Yes. Other folks are. All right. The other thing I would just say about Act 167, and actually this is a good slide to have up, is or was the federal. Oh, right. Okay. Never mind.
Brendan's had it with payment models.
The one, it's okay, Brendan, don't worry about it. The one other thing I'd say about Act 167 is when we passed it, we didn't really know what was possible moving forward with Medicare and what options we might have. And it soon became, and this is just a little bit of background on the AHEAD model. It soon became clear that CMS was not going to do state one-offs anymore. So our initial agreement, the All-Payer Model Agreement, was just Vermont and CMMI, Center for Medicare and Medicaid Innovation, for the folks at Medicare. Maryland had their own, and CMMI basically said it's too expensive for us to do single state one-offs. We're not doing that anymore. But look, we've designed this model. Let's see if I can get the acronym correct. States advancing health equity
Health equity
approaches.
approaches.
And I don't know where the D comes from. It must be demonstration. So they offered us the opportunity to apply for the AHEAD model, which the state did last summer. We were accepted, and the board voted on Friday, 311, to sign on with the governor and AHS to the AHEAD model. So that's, now again, that model brings Medicare to the table for certain payment approaches for hospitals and primary care providers. But I think one of the things we do have to be careful with the AHEAD model is that it's not going to address everything. It has pieces that might help for certain problems, but it certainly won't be the only thing the state should be looking at. And I think
You just got it.
all right.
Yeah. You're not gonna turn into a pumpkin if you go for it. Okay, I mean, is there anything else we need to know? I think you've given us a lot
Yes,
to digest,
yes,
think about, and if nothing else, the complexity of the landscape that we're dealing with, because we do health insurance regulation
Yeah.
in here.
Yeah.
And so most of these proposals will start in health and welfare. They will tell us what they think would be good for people, and then we say what would it cost.
Yeah.
So a lot of the cost containment over time has come through here.
yes.
I know, yeah, Catamount Health got a lot of work in this committee. And we're back in the fray.
Back in the fray.
But we have tried for over a decade and a half, to get a handle on the cost to make sure that people are insured, that they can afford their insurance, and that we are able to provide the care they need. Probably with some mixed result, but we are definitely doing better than a lot of places, and we are a small size and a small insurance pool.
Yeah.
And now an older insurance pool.
Yeah, I mean, the way I would sort of summarize the history, I think, is we've done very well on covering people, very, very well on covering people. And I think actually prior to the pandemic, we were doing a decent job on cost containment. Because we were within 3.5% to 4% growth overall statewide total cost of care, when the rest of the country was much higher, 70%. So we did do, but since COVID, we've seen real disruption in our system with costs and prices getting quite high while sustainability of hospitals is challenged. So I think even though we've had these successes in the past, it is time to, take another look and really think hard about today's environment. And, I don't know why now versus like before, but things have really come to a head.
The interesting thing is that's the same pattern we've seen in the cost of education. We were doing 3 to 4%, and then there was COVID, and then there was 18%. And now we think we're looking at an additional 5%. What happened to the systems in that time? And also we seem we've lost a lot of workers during COVID. The workforce shortage, we didn't hear that much about.
Yeah.
And that's a global dynamic. I would say that's happening everywhere in healthcare.
Yeah. Yep. Okay. We will fix this, right?
We will.
I may or may not. I don't know where I'll be. So you might have to do it without me.
After all these years in battle, I think we deserve a little R&R. Okay. Thank you.
Thanks for having us.
Thank you.
Good years of service.
Thank you. Appreciate it.
Okay, committee. I'm wondering, and I'm looking at the presenters, if I give them a 5-minute break, can you handle that? You can handle that? Okay, 5-minute.
What did you say if I said no?
Stop. Okay, we can go off 1 minute.
Yeah.
Let everybody stretch. Actually, this is crowded enough